Thank you for attending today's event. My name is Jeremiah Beltman, Associate Director, TLL here at Novartis. The Novartis-approved content that will be presented in this session has been created to share important scientific or educational information. The speaker has been trained and is being paid to present this information and support this educational experience from a clinical practice and treatment perspective. If time allows, you will have the opportunity to ask questions at the end of the program. For this event, today's speaker will be unable to address questions that are off-label. Off-label questions can be addressed with a Novartis medical inquiry. Our speaker for today is Dr. Larry Eichenfield. Dr. Eichenfield is Chief of Pediatric and Adolescent Dermatology at Rady Children's Hospital, San Diego, Vice Chair of the Department of Dermatology and Distinguished Professor of Dermatology and Pediatrics at the University of California, San Diego School of Medicine. Dr. Eichenfield has authored more than 400 journal articles, chapters, and books, is a past president of the Society for Pediatric Dermatology, along with a past board member of the American Academy of Dermatology. And with that, I'm pleased to turn the program over to Dr. Larry Eichenfield. Take it away.
Thank you, Jeremiah. I thank people for joining us today. So we're going to be talking about pediatric psoriasis, and actually something I'm pretty happy about, which is the expanded indication of Cosentyx down to age 6 for pediatric psoriasis patients. So something that I think that's really exciting in the field. So by background, first of all, I'm a pediatric dermatologist down at Rady Children's and at UCSD. We have a pretty busy practice. I'm happy to say that we have 5 fabulous dermatology physician assistants as part of our practice group who help us to take care of our patients, along with now eight pediatric dermatologists. We see a fair amount of psoriasis, and I'm excited that we now have expanded indication of secukinumab. So Cosentyx is now indicated for moderate to severe plaque psoriasis in patients ages 6 and older who are candidates for systemic therapy or phototherapy. And Cosentyx has been approved in adults since 2015, and now we have our new indication this year for pediatric patients. I'm going to be reading the standard safety indications in different spots through the discussion. So contraindications, Cosentyx is contraindicated in patients with a previous hypersensitivity reaction to secukinumab or any of the excipients, and there have been cases of anaphylaxis with its use. So the structure of the discussion is basically to review briefly some of the epidemiology of psoriasis in children, emphasizing really skin psoriasis, though we do know that psoriatic arthritis is part of the spectrum. To describe some of the presenting aspects of psoriasis in children, a little bit of comparison with adults, and some of the challenges related to diagnosis, explore the considerations for biologic therapy, and then we'll go into reviewing the core data set that led to Cosentyx's extended indication, looking at the pivotal trials with moderate to severe chronic psoriasis, and then we'll look at the Cosentyx safety data. So pediatric psoriasis, as we know, is a not uncommon chronic systemic inflammatory condition. Psoriasis estimates are about 8 million affected individuals in the United States, including about 128 out of 100,000 children and adolescents. It's interesting that the incidence of psoriasis in kids and teens seemingly doubled between 1970 and 1999. I'm not sure if it's truly a rise in the incidence, or if it's just that we're better at recognizing the disease and or of accessing records to document it. We do know and have known for a while that if you ask adults who have psoriasis when their psoriasis started, a third of them report that it began in their pediatric years. We know that the median age of onset in childhood onset psoriasis is 7 to 10 years of age. And most of this is skin psoriasis. 74% have skin psoriasis, and a certain subset of children will have psoriatic arthritis without skin psoriasis, or skin psoriasis that then develops into psoriatic arthritis over time. In children and adolescents, there's often a delayed diagnosis of psoriasis. Part of that is to some differential in presentation. And just also, I think that by the time adults have psoriasis, it's chronic and it's easy for people to make the diagnosis, but often our primary carers, when primary care physicians seeing pediatric patients or adolescents just don't get that it's psoriasis. But there are some differences in presentation. So, standard plaque psoriasis in adults is usually sharply demarcated, knees, elbows, and scalp being the most common sites of involvement. And in children, you can have thinner psoriasis. The lesions can be smaller. If you look at the images around the eye, for instance. And then scalp is often the first site of presentation. Facial and scalp involvement are both particularly common in children and adolescents. Of course, there's also guttate psoriasis, which can present in children, sometimes triggered by strep. Guttate psoriasis many times will develop into plaque psoriasis over time. Wanted to stress the case for biologics for moderate to severe psoriasis. I gave a lecture recently where I was talking about psoriasis treatment and the sort of step therapy, but I think the takeaway is that step therapy should partially be looked at in relationship to what the severity of the disease is at the time that you're seeing it. And if a patient comes in with moderate to severe disease, you don't have to stop at the bottom step and just wait to work your way up the stairwell. So for mild disease, I think topical treatments can be totally appropriate. And we have our armamentarium of topicals. But when you get to moderate to severe disease, we should understand that a lot of that is undertreated, and increasingly the data supports a move into biologics. So we have had recent pediatric psoriasis guidelines that were put out by the American Academy of Dermatology and the National Psoriasis Foundation in concert, and they indicated that biologics may be appropriate first-line treatment for pediatric patients with moderate to severe psoriasis. And I think that there are some healthcare practitioners who are reluctant to prescribe biologics, and so part of our mission educationally, and one of the reasons I'm doing this particular talk is because I do believe the more we get out there, the more people will understand the utility of the biologics. And also, if you just look at the history, we were behind at least 10 years in pediatric and adolescent psoriasis treatment in terms of incorporating biologics into practice. It's just what happened historically when etanercept was up for FDA extension in pediatrics. And the FDA actually sort of made comments that they didn't think psoriasis was a big enough issue in kids to warrant biologics without having like an extra decade of safety data. And that was wrong. They actually wrote an essay a few years ago saying that they probably had underestimated the impact of the disease on the individuals. But, so we're partly still trying to make up for the time that the biologics weren't readily used, and certainly having our expanded indication in this drug, bringing, our newer biologics beyond the TNFs, and with the incredible success rate of IL-17 directed therapy makes us really excited moving forward. So why an IL-17 a blocker for psoriasis? And the answer, you can find IL-17A in psoriatic plaques, and this is a cytokine that's involved in the inflammatory and immune responses. And sort of our more modern perspective on psoriasis is that you have this psoriasis is aided by these activated dendritic cells that present antigens, and then TNF and IL-12, which then impact on T cells and the IL-23 mediated through IL-23 receptor in the Th17 cells. And Th17 cells squirt out IL-17A, which influences other cells, mast cells, neutrophils, other T cells, and innate lymphoid cells. And so that IL-17 then mediates the physical finding of psoriatic plaques. So add to that a 17A blocker, there's Cosentyx, sitting there in pink coming in, and it selectively binds to 17A and inhibits the interaction with the receptor, and that inhibits the release of pro-inflammatory cytokines and chemokines, and can melt away psoriatic plaques. And we'll go through the data in terms of the evidence of how it impacts on established psoriasis in the age group. So now we'll take a look in at the ability of Cosentyx to work as a potential first-line biologic agent for psoriasis. And we'll start off looking at two sets of clinical trials that support this. The first is this particular pediatric pivotal trial, and this was children and adolescents with severe and chronic psoriasis. And the trial is actually complex because there was a low-dose Cosentyx group, a high-dose Cosentyx group, a set of patients who were on another biologic, and a set of patients who were on placebo. And then the placebo group got randomized to Cosentyx. So I'll show you the chart and the diagram of that. And then there's a second study I'll show you which essentially everyone got Cosentyx. There was no placebo arm, and that was a separate trial. Before I do that, just to go through, they like us in fair balance to discuss some of the potential side effect profiles that were seen. And there are some warnings and precautions with Cosentyx in relationship to the risk of infections. So this is sort of skipping ahead to the safety, but as per label, in clinical trials overall, a higher rate of infections was observed with Cosentyx treated subjects as compared to placebo treated subjects. In these patients with moderate severe plaque psoriasis, there were higher rates of nasopharyngitis as compared to placebo, upper respiratory tract infections, and mucocutaneous infections with Candida. The incidence of some types of these infections appeared to be dose dependent. Now, in post-marketing, there have been some reports of serious and potentially fatal infections in patients receiving Cosentyx, and therefore the label states to exercise caution in using Cosentyx in a patient with chronic infection or a history of recurrent infection. And we should instruct patients that if they have signs and symptoms of infection, they should seek medical advice and hold off on using their Cosentyx. So let's go back to the first study, and it's a busy slide, but an important slide because this is like the core data set. And basically, I'm going to start all the way on the left. Who made it into the study? These were pediatric patients with severe psoriasis, and they had to meet inclusion criteria. So they had to have a PASI of 20 or greater. They had to be severe based on a global score, and they had to have a minimum 10% of body surface area and an appropriate candidate for systemic therapy. And then patients were then randomized to receive either the top row, which is Cosentyx, weekly shot, and then monthly shots up until 12 weeks, or a Cosentyx high dose at the same regimen, or placebo at the same shots, or a subgroup who were randomized to etanercept Enbrel at standard dosing. And if you look over to the right, the takeaway, the punchline is that the Cosentyx low dose, which is 75 milligrams for less than 50 kilograms, or 150 milligrams if you're 50 kilograms or higher, that's the approved dosing. But they also had done a higher dose arm, wondering if higher doses at different weights was going to create more of a higher efficacy result. And you'll see overall not enough consistently outcome measures, so that it was the low dose regimen that was subsequently approved. Now, once you get to 12 weeks, if you were randomized to Cosentyx, not that you knew, the next few weeks you actually had placebo shots because you were really in the monthly time period of Cosentyx, but you didn't know which column you were. So everyone at week 12 still got weekly shots over the next few weeks, and it was placebo if you were on Cosentyx. And patients who had been on placebo were then randomized to Cosentyx, either low dose or high dose. So what were the characteristics of the children who were in the study? So you can see that there were about 3/4 of them, almost 80%, who were ages 12 and older, and the rest were less than 12. A little bit more females than males in the population. Some degree of racial diversity, but mostly Caucasian. Median BMI was about 20-21, so the median body weight was about almost 51 kilos. Baseline PASI score had to be a minimum of 20, you see it was around 28, and the body surface area had to be 10, you can see it's pretty much hovering around 40, so a pretty severe population. And on average, these patients who had an average age of 13 had psoriasis for about 5 years. So out of interest, if you ask, so what else is interesting about this population and their history? About 43% had prior phototherapy, 53% had other conventional systemic therapy previously, only 3% had prior biologics, and 9% had concomitant psoriatic arthritis. So what are the endpoints? So the standard endpoints used in clinical studies are going to be the percentage of patients who made it to clear or almost clear, and percentage of patients who made it to PASI 75. And those were the two composite co-primary endpoints. And then a secondary endpoint, but an important one to us, is PASI 90. What percentage of the people had 90% improvement in their psoriasis? I think something that would have an incredibly positive impact on those individuals. And so let's start on the left and look at the IGA. What percentage of patients made it to the clear or almost clear? And you can see it was at the less than 50 kilogram weight, 32% made it to clear and almost clear. And at the higher weight, it was 81% who made it to clear or almost clear. Overall, 56% clear or almost clear. And then placebo, pretty much nothing. Okay, 5% made it. The EZ75, you can see 55% in the lower weight group and 86% in the higher weight group. And PASI 90 overall was 60%, 81% in the higher weight group, and 41% in the lower weight group. So I think the graph presents the efficacy weeks. This is the 12-week data. Again, at the approved doses we're looking at of 75 and the 150 milligram in that population. And another way of looking at the data is what happens over time, and not just in the 12-week window, but extending on for a year of use. And I really like this. And this also presents the etanercept data by comparison. So if I'm starting at the left, if you look at even week 4, you'll see it's 12.5% of patients who made it to PASI 90. And at week 8, you're already, you're in the 50%, as compared to etanercept, where you're just at, a few percent. At week 4, it's only 2.4%. And you can see then that the curve for the top line, which is our Cosentyx low dose arm at standard dosing, 75 or 150 milligram, you get a very rapid increase. It seems to really start to level off at around 16 weeks with, over 80% of the patients with a PASI 90. And that pretty much persists. It's a little bit of bumping down, but pretty much persists through the 1-year use. So maintenance of response in up to week 52, I think is really, really quite important. And you can see etanercept never, does have gets up to 39%, but certainly a big delta between etanercept. So, and the 17A blocker Cosentyx. So I think a nice time course result. Now, the second study was in children and adolescents, not just severe, also included moderate patients with psoriasis. And this was a study where there was no placebo arm. We have that placebo arm sort of a comparison in the other study. So in this particular study, everyone got Cosentyx, and they got it in the standard methodology, which is week 1, 2, 3, 4, and then monthly injections. And patients were randomized either to the approved dose, again, which is 75 milligrams or 150 milligrams based on weight, but there was also a Cosentyx high dose. And I think this study, you'll see that the low dose results are even closer to the high dose results. One of the reasons I think that moved the approval to go to just the low dose regimen. So this population had a breadth in age, about 40% of patients being 6 to 12, the rest 12 to 18. The median BMI was very similar. Baseline PASI score was around 20, and the baseline body surface area was 30% affected body surface area. There's still a lot of BSA, but again, this is including moderate as well as severe patients. And skin clearance was observed as early as week 4. This is actually, the graph is showing the percentage of responders at week 12 in that low dose group. So again, there were co-primary endpoints. So it was almost 79% had clear or almost clear at week 12, and about 93% had a 75% PASI improvement at week 12. Now, looking earlier, PASI 75 at week 4 had a 62% response. PASI 100 was 60% at week 12, and at week 24, 67%. So for the exploratory endpoints, because they weren't set up in advance, we don't want to make a statistical conclusion, but it shows you a hearty response overall in the population and a significant percentage of the population that made it to an incredible response. And I think this study plus the other one shows this consistency in response to Cosentyx in this particular population in moderate to severe, which is really quite nice. Now, other safety precautions, pre-treatment evaluation for tuberculosis is considered standard. That could be, and so prior to starting Cosentyx, you want to get a baseline evaluation for TB because you would consider anti-TB therapy before initiation of Cosentyx. And that can be done either with a PPD or with a quantiferon. And actually, when we go through the safety study, I'll give away one of the answers, which is that do you need to do blood work prior to initiating Cosentyx and with Cosentyx? And the answer is no, you don't need to, although one could do a blood test if you're going to do a quantiferon as a way to check for tuberculosis. And inflammatory bowel disease, is an issue with this class of drugs. So the caution states that you should use caution when prescribing Cosentyx to someone with inflammatory bowel disease. There were, in some cases, serious reactions to treated subjects was seen, and some new onset inflammatory bowel disease did occur in clinical trials with Cosentyx. An exploratory trial of 59 subjects with Crohn's, there were trends towards some increase in the Crohn's activity and increased adverse events with secukinumab as compared to the placebo group. So what are the safety results for Cosentyx in children and adolescents? And there were, so from, first of all, the safety overall in the age in 6 and older was essentially consistent with the adult population. There was one case of methicillin-resistant Staph aureus toxic shock syndrome in a subject treated with Cosentyx during the placebo control period. Okay, so things happen, not just from drug. There was no drug at that point. In the pediatric safety pool, which includes all subjects who took at least one dose of Cosentyx during the treatment period, 11% of subjects supported a grade 2 neutropenia, with 50% of subjects followed for the 1 year or more, and 30% of subjects followed for 2 years or more. And during the placebo-controlled period, which included 80 patients, there were 41 subjects treated with placebo for up to 12 weeks. But it was had grade 2 neutropenia in 4%. So treated with secukinumab compared to no subjects treated with placebo. So so there can be some decrease in the white blood cells. There haven't been clinical infections associated with this neutropenia. And I already told you the punchline, which is that recommendation for blood monitoring with Cosentyx is considered not necessary. So the summary analysis of the safety neutropenia is that there's no need to look for neutropenia because it doesn't seem to be clinically important. So it's listed in the safety profile, but not something that we test for in our clinical use. This is purposely a lot of data on the slide, looking at the overall safety profile. And basically, the summary box to the right is both easier to read and really gives the summary, which is that this is looking at adverse events at week 12 in the core first study. It shows that if you look at any dose of Cosentyx, the infections were 35% versus 39% in the placebo. GI disorders, 16.3% versus 14.6%. In general disorders or administrative site conditions, 11.3 versus 7.3. So, the most frequently reported adverse events and organ system issues were infections or GI disorders or skin cutaneous disorders, but the data is generally reassuring. And this is looking at treatment emergent adverse events in the extended through week 52, and you can see very similar numbers over to the right. So important identified and potential risks up to week 52 are listed here, but with those particular categories being listed, but it's not like there's additive effects with continued use of Cosentyx in those individuals. So overall, the safety profile now is expanded because now it includes the 6-year-olds plus. And I think these summary bullet points, so to speak, are really important. So this medicine has no boxed warning. So we have to say, look at the safety information, including contraindications, but it has no boxed warnings. That there were no emergent safety signals observed in the 1 year of use. As I pointed out, there's no routine laboratory monitoring requirement. Again, PPD testing or quantiferon for tuberculosis at baseline, and then it's usually standard with biologics that go ahead and make sure patients are up to date on their vaccinations prior to initiation of a biologic agent. But there's no baseline monitoring and no blood work beyond that. And then the safety profile, I think, is consistent across the trials in the kids and adolescents, and also very similar to the adult. And then it's hard to say this without saying we don't like to compare and contrast, but not all biologics for psoriasis have this relatively clean bill of health in relationship to malignancy. And the 17A drug, secukinumab, looked really good with that. So no malignancy or unspecified tumors were reported. in the 52-week studies, and leaves a 0 incidence rates over 100 patient years. So I think that we're very happy to have the additive data set in children and adolescents, and I think this is very consistent with what was seen in the adults as well. Now, in terms of administration, I sort of stressed the dosing, but this is the punchline, is that basically there's either 75 or 150 milligrams based on weight. And, in pediatric patients, basically you do your sort of standard subcutaneous injection at baseline, and then weekly, and then maintenance doses every 4 weeks. It's a removable cap on the Cosentyx, in the Cosentyx pen, with the 1 ml and 0.5 pre-filled syringes. If someone's latex sensitive, you should be aware of that, because that could be an issue. And certainly in our kids, it's expected that the guidance and supervision of an adult will be there. Adult caregiver should be doing the injection, and pediatric patients shouldn't be self-administering their doses. We've gone through the warnings. This is just reiterating hypersensitivity reactions and including the story about, if natural rubber latex being at the end of the pen, that immunizations, it's recommended that they be age-appropriate immunizations be finished up prior to initiation. And then, right, when we see FDA labeling, they usually have a discussion of what occurs at a rate of 1% or higher. And when the Cosentyx is nasopharyngitis, diarrhea, and upper respiratory tract infections being the things that are listed at greater than 1% rate. So putting it in context, so we want to be aware of our pediatric psoriasis patients. There's other studies not included in the slide deck that have been put together looking at over the last few years that really have given us more data on pediatric psoriasis. There was one comparison study of traditional systemic medicines as compared to biologics that looked very positive for biologics as well. Certainly the guidelines, AAD, NPF guidelines we discussed as well. So I think pediatric psoriasis has a significant burden, a significant impact on the life of affected individuals. It also has a delayed diagnosis, frequently misdiagnosed. The AAD NPF guidelines highlight considerations for biologic therapy, and we're, I think, very pleased that Cosentyx now has this expanded indication based on these two pivotal trials, one with severe psoriasis, one with moderate severe psoriasis, and that we can do this with a safety profile that's consistent with that seen with adults with no new safety signals over time. So I think it's an important time in life of psoriasis patients as we start to have expanded indications of our newer biologic agents for psoriasis. And that is the general discussion, though we certainly have time set up for questions or comments. And I'll turn it over to our moderators who can then feed me any questions or comments that people want to make. It looks like no questions at this point, but don't be bashful typing them in.
Absolutely. Why don't we wait just another moment or two here, and we'll see if any questions come in.
Okay, thanks, Jeremiah. Well, if we don't have questions, as Jeremiah said, you can seek out your Cosentyx rep. If it's something off-label that you want my input on, it's not part of the thing, you can feel free to email me if you have psoriasis questions. Eichenfield at ucsd.edu is probably the easiest one to remember because I am down at UCSD in San Diego.
Okay, well, it looks like we've waited a couple minutes.
Wait, there's a question. Okay, let's see if I can Is there any efficacy safety data extending past 52 weeks yet, since pediatric adolescents will need lifelong treatments, wanting to know if the efficacy sustains itself? Yeah, so actually, the answer is this is the data set that's out now, I'm not certain of what extended data set is in process. I'm not sure if anyone else on the call can let me know that, but I do think that what we do have, of course, is extended data sets from the adults, and in other with our other biologics, it seems to be that the absence of waning with regular use. We're not talking on and off use because I'm concerned about when you get antibodies against the antibodies. I think the idea would be that there would be a consistent response over time. No blood work necessary except PPD. Well, PPD is not blood work, but I just mentioned. So quantiferon is a blood test, right, which you can do. If you do a PPD, you don't need any blood work at all. But if you want to use, I didn't want to say there's no blood work if you're getting a quantiferon because that's a blood test. Do you recommend getting COVID vaccine with no delay in treatment for kids? So, yeah, so obviously, well, I should say obviously, but there are no studies of COVID vaccinations on children who are on Cosentyx. Most of the advice in relationship to biologics for psoriasis as compared to other immune suppressants is to vaccinate. And some people will sort of vaccinate in between the standard dosing, usually not at the same time, though there's no contraindication. So, if someone were, with children, it depends on their age, whether they're eligible for vaccine now. I'd probably try to immunize them if it was available first before initiating Cosentyx. Caution with chronic infections. Does that mean recurrent hepatitis or MRSA? No. So that's one of the interesting things about psoriasis is that we tend not to get a lot of impetiginized psoriasis. Probably has to do with some of this is me talking, not the deck, that, some of the native defense proteins are upregulated in the inflammation of psoriasis, and we don't have some of the relevant deficiencies that we see in atopic dermatitis. I think it's just more secukinumab as an IL-17 is it's one little part of the immune system. There was concern about candidal infections because that's a pathway that can handle candidal infections. But then there's just the overall concern about, is it immunosuppressive in some way? And so it's listed on the label, but not something that's generally seen in clinical practice. So, but I mean, I'm not going to take away what it says in the label. You need to counsel based on the label, but the actual clinical infections seen are at a very low prevalence. The Sensia Ready pen coming for 75 milligram dosing. And Jeremiah, do you know what the story is with that?
No, we don't have any update on that yet. Again, we're sticking with what we have at this point. When those updates come, we'll certainly get that information out to everybody.
Yeah. And the next question: what's your opinion on using this in peds adolescents who have a first-degree relative with IBD but no personal history? So clearly, this is where the label helps, right? Because the label clearly states that you should discuss discuss the risks. So this would be a risk-benefit analysis that I would discuss with the family, and you could discuss other biologic options. But of course, it's different for an individual than a first-degree relative because but no personal history. And I think that it's a judgment call. It probably depends on what their history of inflammatory bowel disease is, how affected the individual might be in terms of their willingness to consider it. And if they're concerned, there are certainly other biologic options that don't have that labeling in relationship to inflammatory bowel disease. But if they're comfortable because this is the right your sense this is the right drug for them. It's reasonable as long as they're appropriately counseled. If a patient has a history of MRSA or recurrent impetigo, should they avoid Cosentyx? And I would say, not really. It's not like, they didn't, I don't think there were these, it's totally different than atopic dermatitis in terms of the underlying state being associated with intermittent MRSA. I would, or impetigo, I'd probably just do the usual treatment and or concurrent treatment. Those are patients who sometimes you try to do eradication or you do intranasal Bactroban and bleach baths or something, and I probably wouldn't let that stop me from using Cosentyx. So I think that'd be reasonable.
Okay, looks like that last question there, Dr. Eichenfield.
Okay.
All right, once again, thank you so much for delivering the deck. I really appreciate it. Thanks for all the people out there in the audience for taking your time this evening. I'd like to extend a special thank you to you as well. Hope you guys have a fantastic rest of your evening wherever you are. And again, thank you again. Take care.